This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 2, Acute Coronary Syndromes. Key concepts. Upon completion of this chapter, you'll be able to understand these concepts. That coronary heart disease is the #1 killer of Americans of both genders. How the anatomy and physiology of the heart are the key to the cardiac conditions. That chest pain or discomfort is a primary complaint of most persons experiencing an acute coronary event, although respiratory complaints, weakness, fatigue, malaise may also be presenting complaint, as well as chest pain. Myocardial infarction is death of heart tissue. Treatment varies for ST segment elevated MIs compared to non-ST segment elevated MIs. How angina occurs when oxygen demand exceeds oxygen supply to the heart. The cause of pain, infections, damage to the pericardium, valvular disorders, vessel disorders, or specific respiratory, musculoskeletal, or GI disorders. That initial treatment for acute coronary syndromes include oxygen intravenous access, 12-lead EKG, and nitrates. How the result of the 12-lead EKG can help determine further treatment and destination. Chief concern. Many different causes of chest pain. Some are cardiac in nature. Coronary heart disease would be an example of this. And there are others that are condition or disorders in nature. Heart disorders like structural or electrical problems. Acute coronary syndromes, consideration. We should always consider the symptoms. What kind of pain is the patient actually having? Are they having chest pain, pressure? Is it substernal, left-sided, right-sided? Did it radiate somewhere? We should also get the associated symptoms with this. Most often, it is associated with nausea, dyspnea, or difficulty breathing, and diaphoresis, which is a sweating of the skin caused from hypoxia from a major organ system and shunting towards the core. The pathophysiology of acute coronary syndromes often is a long time chronic thing where it builds up, atherosclerotic plaques build up until the point that an intrinsic pathway or platelet-originated pathway starts the formation of the clot, and it slowly closes the lumen. So this is like a progression. Hyperventilation syndrome can lead to coronary artery spasm and chest pain as well. Contributive factors on this is going to be panic disorders, agoraphobia, and stimulants such as caffeine. Treatment of this focuses on the hyperventilation itself and may include sedatives and or antipsychotic medications. Myocardial infarction or death of the heart cells is another consideration. Coagulation cascade is initiated. This causes the clot to propagate or get larger and ultimately completely occlude the coronary artery. The ST segment elevated MI versus the non-ST segment elevated MI. A STEMI event is an acute injury. Please refer back to 12-lead on this. A non-ST segment elevated MI may give us nothing more than an inverted T wave. It may not give us anything at all. So there's an importance with this. Please treat your patient clinically. If they are still suffering from chest pain, you think it's non-pleuritic and non-musculoskeletal, treat them as if they were having a cardiac event. Acute coronary syndromes continued. Non-ST segment elevated myocardial infarctions. Whenever we look at non-ST segment elevated myocardial infarctions, an example, just like on here right now, this would still be things to look at. ST segment depression, partial thickness, or a subendocardial MI and an inverted T wave. 2-3 and AVF. This says ischemia. This says that I may have a partial thickness. So, cocaine-related injuries and coronary syndromes as well. Too much output. The cocaine is an amphetamine, speeds up the heart. Very simply, it can cause too much demand to be put upon what you have a supply for. EKG findings are suggestive of myocardial ischemia, included T-wave inversions or ST segment depression greater than a millimeter and at least 2 anatomical contiguous EKG leads. This EKG is from a patient who has an inferior wall ischemia. And that would be what we were seeing right here. Cardiac infections. All of these things that we're talking about here can cause chest pain. Pericarditis is one of those. Inflammation of the pericardial sac can be caused from infections, malignancies, medications, systemic inflammatory conditions, renal failure, or after a myocardial infarction. Endocarditis, an infection of the endocardial or inner layer of the heart, which includes the valve tissues and the inner surface of the chambers. It may also affect any artificial valves which have been implanted or replaced a diseased valve in the past. Myocarditis would be an inflammation of the myocardium. Can occur from an infectious cause, toxicity from both medications and environmental poisons, as well as rheumatological or autoimmune disorders. Valvular disorders occur acutely or slowly and progressively. Valve stenosis, which means hardening or scarring of the cardiac valves. Hemoptysis, coughing producing either frank blood or bloody sputum. Classic symptom patterns is going to be difficulty breathing, chest pain, and syncope. Valvular regurgitation. Regurgitates the blood flow across the valve when the valve is incompletely and cannot prevent the backflow. So if you have regurgitation, it's going to regurgitate into the previous chamber. Tricuspid and pulmonary valves. End result, a patient with either pulmonic or tricuspid regurgitation signs or right-sided heart failure, including increased JVD, hepatic distension, and abdominal tenderness and peripheral edema. Very simply, look over this one more time too. It's always going to spill into the previous container. Right and left. And we're all connected with vessels. The previous container for the right heart is the periphery. The previous container for the left heart is the lungs. So if they're in left heart failure, we should expect to see pulmonary edema. If they're in right heart failure, we should expect to see peripheral edema. Pulmonary hypertension. Elevated pressure in the pulmonary vascular system may develop gradually or acutely, varies in causes, chronic obstructive pulmonary disease or COPD, stimulant use, liver disease, obstructive sleep apnea, chronic pulmonary embolism, and systemic collagen vascular disease. So anything that would either clog the pipes or cause a regurgitation into the right ventricle or cause a backup or higher pressure can give you pulmonary hypertension. Non-cardiac causes of chest pain. There are many causes, and we should consider anything. Has a patient been coughing a lot? Have they had any kind of chest trauma whatsoever? Dissection of the thoracic aorta, kind of an uncommon condition. A small teardrop develops on the intima layer of the aorta, and this balloons off and can occlude vascular feeding or the ability of the heart to perfuse itself. History. Considerations. We should consider the symptom pattern. Is it substernal chest pain? Is it with or without radiation to the neck or left shoulder? Or does it just stay in one location? Do we think that it's a myocardial by presentation? Patients that have an acute myocardial infarction that involves the anterior wall generally have classic symptoms. Patients who have an acute myocardial infarction of the inferior wall are less likely to complain of classic symptoms, but have epigastric discomfort and may be experiencing vomiting. Atypical presentations occur sometimes as well. Women under 60, elderly, long history of diabetes. The OPQRST ASPN mnemonic helps us identify and keep clarity in our answering or our questions. What time did it onset? Does anything make it better or worse? Provocation. Quality of pain. What does this actually feel like? Radiation. Does it go anywhere? Does it stay just in one location? On a scale of 1 to 10, 10 being the worst pain you ever felt in your entire life, what do you think this pain is right now? Timing. What time did all this start? Does it come and go? Is it consistent? Any other kind of associated symptoms that I should be worried about? And pertinent negatives. So an example of this, they lift their arms above their head and their chest pain goes away. That would be a pertinent negative. But if it's constant, it doesn't get any better or worse, it stays in one location, those are all bad signs. A crescendo angina, increasing frequency of symptoms over time, and may indicate progressive coronary artery disease. So it gets worse, and worse, and worse as time progresses. Examination. Procedure, we should get a 12-lead ECG on these patients, determine appropriate hospital destination, and the speed of treatment. Serial EKGs consider if the patient becomes pain-free during the contact. This would give us a history of what actually had occurred. Abnormal vital signs like hypotension, unstable dysrhythmias of any sort, or airway breathing and circulation issues must be immediately addressed. So as soon as you see any of those issues, you got to jump on those. Focused examination on the cardiovascular, respiratory, gastrointestinal, neurological, and palpation of the thorax would be the key areas that we're going to examine on this. Assessment in the respiratory symptoms, and this would be sharp pain that changes during respiratory cycle, often worse with deep inspiration. So they take a big deep breath and it gets worse. Signs of respiratory infection, they're coughing up, they have a productive cough, including fevers, productive cough, tachypnea, tachycardia, and hypoxia. Gastrointestinal systems, burning pain that begins in the epigastrium and radiates up to the center of the chest and throat. Sour taste when waking after sleep. Worsening symptoms at bedtime. And symptoms worsening by certain foods. Those would all be, I have GERD or GI problems. Acute pericarditis symptoms. Pain is often sharp and non-radiating and improves when the patient leans forward. Worsening when the patient leans backward. It's also suggestive when a classic EKG findings are present, and that would be a smiley face concave ST segment. 12-lead EKG divides acute coronary syndromes and treatment into categories. The categories, very simply, depends on what is located on the 12-lead EKG. So this is a quick breakdown, and I'm going to go ahead and minimize this so that we can see. Initiate ACS measures. Obtain a 12-lead EKG shortly after initial assessment. Interpret the EKG. If we think it's a STEMI, let's jump on it. Consider percutaneous possible angioplasty. Hospital treatment on this is going to be fibrinolysis versus angioplasty. Beta blockers, anticoagulants, heparin, Plavix, clopidogrel. Admission to a coronary care unit or transfer to a PCI capable facility or angioplasty capable facility. If the 12 lead was normal, continue the nitrates. We're going to err in the patient's favor. Hospital treatment, low risk. Very simply, they can run a troponin test and see over a time period if the person pops hot on it. ST wave or T wave inversion or ischemia, continue the nitrates. IV fluids for hypotension, hospital treatment, anticoagulants. They may administer them to CCU or get cardiac enzymes. Cardiac enzymes. This one here hasn't got cardiac enzymes in it, but they probably would draw them quite rapidly if they have a STEMI event. Treatment of a STEMI event or a non-STEMI event or an ACS in general, acute coronary syndrome, any chest pain, is going to include oxygen if the patient's hypoxic. So how do we determine hypoxia? We determine hypoxia very simply if their SATs is less than 94%. Now we gauge variations of hypoxia as we get lower than 94%. If they're not allergic to aspirin, we should give aspirin. It decreases platelet aggregation, or the platelets from sticking together. So we've kind of stopped the process that got them there to begin with. The nitrates dilate out the venous side, or a good venodilator. At higher doses, they're an arterial dilator. Morphine sulfate. This is somewhat controversial in the morphine sulfate. It masks the pain and doesn't get them so aggressive on the cardiac end of it. Now, morphine sulfate at 2 to 10 milligrams can be given, but this is whenever it has not been effective by nitrates. Beta blockers or adrenergic blockers decrease the contractile force strength in the heart, reducing myocardial oxygen consumption. And then last but not least, anticoagulants. Anticoagulants would stop the intrinsic or extrinsic pathway, depending on which ones we are using, and decrease the common pathway formation, thereby decreasing clots that were being made in the lumen of the vessels. Evaluations. Consider the complications of any kind of the medications that we talked about, including nitroglycerin administration. Be sure they have ample pressure and that you have a good IV in place. So in case the patient does need venous fluids, you can give them to them. A right ventricular myocardial infarction does not do well with nitrates. They are especially if they're preload dependent. Let's talk about that here for a second. We have a heart that is having an isolated right ventricular infarction and having problems getting blood into the pulmonary trunk already. We give them a squirt of nitro, and nitrates decrease the preload. The reason they decrease the preload is this vessel that was once this size now is much larger. That decreases the amount of pressure that goes into the right heart to begin with, thereby making your patient hypotensive. So very simply, be sure you have an IV in place. If they have a right ventricular infarction, this would be ST segment elevation in 2, 3, and AVF with a right-sided 12 lead that had increased ST segment elevation. That's the easiest differential diagnosis. An inferior wall presentation that you do a right-sided 12 lead and you find ST segment elevation. Mitral valve regurgitation. Under stress, very simply, it can regurgitate into the previous chamber, decreasing cardiac output. Aortic stenosis, use caution when administering nitroglycerin, involves a patient, and the patient has aortic stenosis. Nitroglycerin dilates systemic veins, decreases the volume. If the preload drops significantly, the patient loses blood flow and may become profoundly hypotensive if they have aortic stenosis. So these are all considerations and complications of nitroglycerin administration. Disposition. In-hospital treatment changes dramatically based upon the 12-lead EKG findings. If we are in the middle of a STEMI event, the goal is to open the occluded coronary artery very rapidly, and we can do this in 2 methods in the hospital. We can do this by clot busting, which is to give them a medication that takes plasminogen to plasmin and busts the actual clot, or we can do this by angioplasty. And an angioplasty involves a stent, where we go in there and we balloon out the vessel and then place a stent to keep the lumen of the vessel open. A decision to preferentially transport is based upon the resources, and the resources of the hospital. Let me clear this off here before we go to the next one. Fibrinolysis or clot busting. Less than 3 hours onset of pain, Contraindication to angioplasty would be our choices here. So if we're thinking clot busting, they're going to have a contraindication to angioplasty. No contraindications, though, to the clot busting or fibrinolysis. Primary angioplasty, greater than 3 hours of onset of pain. Contraindications to fibrinolysis. Heart failure present at the same time as the MI. And this is where this study came from. AHA Part 8, stabilization of the patient. So, in conclusion, the American Heart Association issued treatment standards, and they issued treatment standards off of STEMIs, primarily angioplasty and clot busting or fibrinolysis. Acute coronary syndromes that are not a STEMI, it also issued things on that. So we still treat them with nitrates. We err in favor of our patient until we can get them better evaluated. Valve rupture or aortic dissection is also a possible complication. We should treat them symptomatically and clinically. If they are presenting with chest pain, treat them clinically. References for this were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies, Maternal Health and Pediatrics, Del Mar Learning. If you have any questions concerning this section, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.